Education points. How to manage nausea and vomiting during outpatient ketamine infusions. Importance of outpatient ketamine infusions after ketamine coma. Role of having children after ketamine coma.
Okay, Elizabeth, it's now the day after your third ketamine infusion, and we got you up to 200 milligrams an hour of ketamine. And let's first talk about how things went during the infusion, okay?
Okay.
Now, we were able to get you up that high. What would limit us in going any higher is that it was depth of anesthesia. It came a point where you were unable to respond to simple questions like, what state do you live in, okay? In fact, we did a little video clip, and we'll probably include that along with this so people understand what it is, what that means when you can't answer a simple question like that. So that would really limit us. There was another issue that came up which didn't limit us, but did create some post-operative issues. We knew from your history that you're very sensitive to all medications.
Yeah.
Nausea, vomiting is not an uncommon problem with anything you take. In fact, 20 to 30% of all people will develop nausea and vomiting as a result of getting any type of anesthetic. Okay?
Right.
And so I thought what I would do here, take this opportunity to kind of make this a little educational for everybody, including yourself here, and discuss that. We know there's two factors that are involved. I'm going to close this door for a second here.
Okay.
The noise down. There's two factors involved. One factor is the drug. We know, for example, the opioids, the narcotics, are notorious for triggering nausea and vomiting, okay? Some more than others. We also know that ketamine is least likely to cause nausea and vomiting. Yet, in some people that are very sensitive to medications, they will get it. In fact, in my experience doing hundreds and hundreds of ketamine infusions, that it's the most common complication we run into in a few group of patients. And by the way, it's far more common in women than men. Okay, so we know that. So you just happen to be one of those that are susceptible to that problem.
I'm the lucky few.
Right.
Yeah.
And so what do we do with patients like that? Well, one of the things we do is what we did in your case. We gave you 24 milligrams orally of Zofran 1 hour prior to the procedure, and that's called prophylaxis. Okay, to minimize that risk. Another thing we did is that we made sure that you didn't have a lot of saliva in your mouth. Having a lot of saliva in your mouth during ketamine infusion is uncomfortable. It may feel more like somebody sticking a finger in your mouth, okay? Make you gag. So we kept you dry. We gave you a drug called Robenal to minimize a lot of secretions. Of course, after you're done with the infusion, you're going to have a dry mouth for an hour or so. But that can easily be treated. But if you're feeling queasy and nauseated, that's a far worse situation after ketamine infusion. The other thing we know, and studies back this up, you want to make sure patients are well hydrated, okay? Now the trade-off on that, if you're doing a 4-hour infusion, the bladder can get pretty full, okay? But that's just one of the things that you have to deal with, but the point is that you don't want a patient getting dehydrated. Okay, another thing that we know is that when patients are done with their ketamine infusion, if you just turn it off and do nothing, they wake up very fast. And waking up very fast can make the patient feel queasy. So we make sure we give lots of Versed at the end, a sedative, to make it so that you wake up very slowly. The other thing we know is, and again, a reason why to keep you hydrated, is after a ketamine infusion in somebody that's very susceptible to nausea and vomiting, is you don't want to give them a lot into their stomach all at one time when they're done.
Yeah.
As you know,
yes.
right?
That didn't work so well.
Right. So you keep them well hydrated, and if they're going to sip anything afterwards, just small sips, okay? So these are all tricks of the trade, things that we do to minimize that risk, okay? So tell us how it went for you. First, we had to figure out what was right?
Yes, we
So
had to.
did it improve over time?
It did. Each day was progressively better. The first day, I remember even during the treatment, there were several points that I felt nauseous, and it took me a little bit to really realize what was wrong. I just felt off. And then the second day, I believe there was only maybe one time where I felt a little bit nauseous during there, and you gave me some medication for that, and that went away. But at the end of each treatment, I felt really nauseous. I think I threw up twice the first day. The second day, but the second day, like I said, the treatment itself was easier to go through. And then, you know, after throwing up a few times afterwards, I felt okay. I just had to kind of sleep it off. About a 2-hour nap, and then after felt fine. Then the third day I got sick once, but resting, laying still, closing my eyes after certainly was a great benefit. So I only got sick once the third day, and then the same thing, just was able to go back to the hotel and take a little nap, and then I felt fine.
Right, so you made some very important points, so let me summarize those. Okay, point number one is that we know it wears off over time.
Yes.
We know that if you can take a nap and close your eyes, that can help overcome it, right?
Yes.
The other thing we know that if then some people, if they're going to drive in a car, make sure they keep their eyes outside the car looking around so they don't get motion sickness, right? On the other hand, if you're in the car, it might be better for some people just to keep their eyes closed, okay?
Yes, for me that was better.
And make sure the driver goes around corners very slowly, right,
Yes.
Matt?
No
Am I right?
No hairpin turns on the
No
way home.
no hairpin turns, right. Because what happens is the vestibular apparatus in your ear, those little balancing things start moving around, and you can't see what's going on, and that can trigger a sense of nausea, okay?
Sure. We did take a U-turn on the way out of here, and I took it very slow. Just waited till there was plenty of room.
Exactly.
And,
Exactly.
nice and easy on the way home.
Good point. Excellent point. Now, the next thing we're going to do is first of all, let me summarize how your pain thresholds turned off. There was a definite improvement, especially in that right upper extremity. And we're going to measure that function here in a minute. But the point is your pain thresholds improve, and that's an objective measurement of outcome, isn't it?
Yes.
Okay. Now, the next thing we want to do here is we want to go ahead and do some of this testing, functional testing. Are you ready for that?
Sure.
Okay. First thing, the vertical finger test. You remember that? Look straight ahead. Don't follow me.
Okay.
Get your 2 fingers in your mouth. Okay, good. All right. Any pain when you did that?
Nope.
You didn't have any pain?
Nope.
When we started? And Dr. Kirkpatrick didn't create any new pain, did he?
No, still
all right,
there.
all right. Just want to make sure. Next thing I want to ask you to do is take that right hand, put it behind your head. Okay, any pain when you do that?
Nope.
You didn't have any pain when we started, and we have no pain now. Now, we had some serious issues with that left upper extremity, didn't we?
Yes, we did.
So remember, you couldn't get it very high at all. So let's see what you can do now. All right? So you can get it back there. So you think you could comb your hair now?
Oh, yeah.
Well, you couldn't do that before.
No.
Okay. And if you're, by the way, just while you got it up there, I want tell me, do you have any pain at all when you do that? And if so, where is it?
Yeah, there's just some slight soreness, I'd say, in through
Right.
here, but not not very much at
And
all.
what did we say about soreness? Soreness can be just that you're out of shape because you weren't really using that extremity, were you?
No.
All right.
Yeah.
So over this 3-day period, you've been using it probably, and so you're not, so I expect that to improve over time. Next thing I want you to do is take that right hand out in front of you, please.
Okay.
Open and close fast as you can. Good job. Good job. Now to see what you can do now. You can hardly do anything with that hand before, so you can now grab onto things, can't you? You couldn't do that before.
Hopefully not dropping things as much. That'll be
Right,
good.
right, okay. Okay, the next thing I want you to do now is we're going to turn our attention down to your feet and your right foot. Take it off the ground. Rotate your ankle, please. Wiggle your toes, okay? Hitchhike back to the east coast of Florida. There you go. Now on that left, do the same. See, that's much better than before, isn't it?
Yeah, it feels much looser.
Yep, and wiggle your toes. Okay, very good. Excellent. Good job. Now, the next thing we're going to do here is we're going to get you up here, and I'm going to ask Matt to be your safety net. He's going to be standing next to you here, okay?
Okay.
Why don't you go over here and stand up? There you go. Okay.
Right side, left side?
Yeah, right side.
Yeah, the right side would be better for you. Yeah, there you go. Now, I want you to take 3 steps toward me, please. Got it, girl. Good job. And 3 steps back, please. You're not limping as much now, are you?
No.
Okay, that's good. Now, remember you had pain that went all the way from your foot out the lateral side of your leg all the way up into your buttock region, remember? What's going on now?
Now I just have, it feels like there's maybe a band tight around my ankle.
Okay.
It feels sore, and my knee feels really raw. But
Right.
there's no radiating pain.
Right. Now, your knees are weight-bearing, and so are your ankles, right?
Yeah.
And again, I think a lot of what you're feeling now is just the fact that you're out of shape,
Yeah.
okay? All right, very good. Now, the next thing we're going to do here is we're going to challenge you a bit here, okay? But we don't want to cause you to re-injure yourself. Okay. So, Nat, take her right hand. Don't use them unless you need them. Remember, you couldn't even get up on your toes before. See if you can get up on your toes now. There you go. You're up there, aren't you?
Yep.
Good girl. Now, I want you to see if you can take 3 steps on your toes. See if you can do that. If you can't, you can't, but give it a try. There's 1, 2, 3. Yeah, you couldn't even do that before.
No.
You can go on back. Now, just see if you can take a couple of steps on your heels now. Remember, you couldn't do that before.
No.
Okay, very good. Good job. Good job. Go on back. Now, this is a real stressful thing we just did with you, isn't it?
Yeah.
And my question is, is the pain different now? Is it more focal, like you just described, more in your knee and your ankle?
No, it's very localized pain. Just
it's not that diffuse, doesn't cover the whole leg.
No, it doesn't radiate when I do things.
Okay, go ahead and have a seat, please. And Matt, would you do me a favor? Would you pull the chair up closer to hers for me? Makes it easier for me. Sure. Now, I think one of the take-home messages is this: you had your ketamine infusion, your ketamine coma about 6 years ago in Germany, right? Mm-hmm. And the point is, you really haven't had much in the way of ketamine boosters in the meantime, okay? Yeah. And so things have accumulated quite a bit on you here. And I think one of the important things is, for those patients that have been through the ketamine coma and have an exacerbation like you have, that it is, go ahead, Matt's going to do me a favor here. He's going to close the door so we don't have so much noise out there. We know that there is a solution. There's something that can be done to get you out of the bind that you're in with an exacerbation of pain, CRPS pain, following the ketamine coma. So that's very important. Yeah. So I think that's an important take-home message. Now, the next thing we want to do here is we want to go over the treatment plan, okay?
Okay.
All right. So I anticipate that you can make further improvements without ketamine. And here's how it works. It's called heated pool exercises. Hopefully, if you can tolerate it, 3 times a week. Okay. And I mentioned to you before, there's 4 important reasons why that is key. Number 1, you're not ready for weight bearing on that left foot yet. Yeah. You're not ready. And so buoyancy is point number 1. Point number 2 is the most common reason for relapse is re-injury. Mm-hmm. And being in the water is an exercise where you're least likely to re-injure yourself, okay? And then another reason is that water can be a further desensitizer. Your pain thresholds aren't quite normal yet, okay? I expect those with making contact with the water that'll further desensitize those pain receptors in your muscle, okay? Okay. And number 4, water can be a profound stress reliever, profound. So you make sure it's in a quiet area. You don't have the kids running around and all those distractions, so you can just sort of meditate a little bit when you're doing your water exercises, okay?
It's not relaxing to have them squirting you in the face with water.
No, or yelling and screaming and all that kind of stuff. Right, exactly. Now, so here's the thing. I'm going to ask you a question here. Test time. Are you ready for this?
All right.
So you go and you go in the water. Mm-hmm. You do your exercises.
Yes.
You get out.
Yes.
And you have no pain.
Mm-hmm.
Is that good or bad?
Bad.
Okay. Why is it bad?
Because you want to push it a little bit, not too far, but you want to be working your muscles.
All athletes will tell you when you're out of shape, and you're out of shape, not through no fault of your own. You're not lazy. It's just that you couldn't with the CRPS. Yeah. And so you have to have a little soreness in order to make the gains that you need in your exercise tolerance. Okay?
Yeah.
Now we talked about measuring your exercise tolerance, didn't we? Mm-hmm. As a way to gauge whether you need another ketamine infusion. So let's just say, you just sort of tread water back and forth across the pool, and let's say you can only do 1 lap the first time. Next week it's 2 laps. Mm-hmm. She's making progress in her exercise tolerance, right, Matt? Yes. So she doesn't worry so much about having another ketamine infusion under those circumstances, okay? If you're not making that progress, or if you're going the other direction, you probably need another ketamine infusion, okay? Yeah. All right. Now, we talked about the fact that you can get a little soreness. We call that a good hangover, right? Mm-hmm. But on the other hand, if you get in the water and you're laid up for 1, 2, or 3 days, that's called a bad hangover, right? You don't want to do that, right?
No.
Okay?
Yeah, not like what I'd been doing to myself.
Right. We also talked about, because you don't live in a bubble. We don't want you living in a bubble. Yeah. Bad things can happen. You can injure yourself. The kid steps on your foot accidentally or something, okay? So, I suggested that you probably want to video record your functional measurements that we did on you, maybe once every 2 months or 3 months, so that you can see the progress you're making, have an objective measurement over time. So video recording, your exercises that we put you through, your baseline exercises, is going to be a helpful thing to keep your mind on the right track. Yeah. Now, there's a 4-letter word that nobody should use around you. What's that word called?
Pain.
That's right. Yeah, we want her to focus on the F word, right?
Right.
Come on, Matt. What's that word?
Functional.
Yes. Function.
Not that one. Yes.
Not that one.
Yeah.
Function, right? Function.
Yeah.
So it's important because this is kind of a little mind game you got to go through with this disease. You know what I mean? So you're going to focus on function because that's going to be your most reliable indicator of how you're coming along.
Yeah.
Now, you ready for another question?
Sure.
All right, you ready? All right. Well, hey, we picked on you enough. Let's pick on Matt. Okay, Matt, is there a role for narcotics, the opioids,
Yes,
like
there is.
morphine and Vicodin and all that in treating RSD?
There is.
Okay,
yes.
explain that to me.
To a point. If you have an injury, say, like you said, the kid does step on your foot, something like that, then you can, I don't want to say numb it, moderate that a bit, keep it in check, so it doesn't get out of control and the RSD flares up again.
Yeah, right. So we talked about how the acute pain is a totally different mechanism. It will respond to narcotics if necessary.
Right.
And you have to control it because if you don't,
Then it's going to spread and flare up.
it's going to flare up your RSD.
Yeah.
So that's why there's a critical role if you need to take them. And in your case, we talked about, since you are very sensitive to medications, that there are some other medicines besides morphine that probably will least likely to trigger some nausea and vomiting in someone like you.
Yeah.
Okay? Go to the dentist. We talked about how you have to make sure that he numbs that area down really good.
Yes.
Okay? All right. Okay, so we covered a lot of territory here. So let's turn over here to Matt. Matt is is he your big brother, or I can't remember?
He is.
He's your big brother. Okay.
Yeah.
Okay, Matt. Do you have any questions at all? Anything?
Not questions. We were going to talk about some of the things that I noticed during the coma treatment, or not coma, the ketamine treatment rather.
Okay. Yeah. Right. Anything that you've noticed? Any improvements or any problems or anything?
Definite improvements.
How about in her mood? Is her mood picked up? Is she
Much more. Yes.
feeling more hopeful
Yes.
now? Yeah.
Yes.
That's
And there's
really
always the anticipation before you go into something. You don't know how it's going to turn out.
correct.
If you're going to get positive results, if it's just going to make things worse.
Exactly.
Kind of fear of the unknown,
Yes, absolutely.
dreading things.
Well, yeah, and she's
definitely seen positive
had
results
ketamine
already.
boosters before, but they were very low doses, and she was going to get in.
Right.
Dr. Kirkpatrick was going to kick her, you know what,
That's
with
right.
ketamine, right?
And we did, yeah.
And we did. Right.
Yes,
Right. Okay. Do you have? So you notice improvement in mood. Another problem these patients often have, which we haven't talked about, is controlling temperature. Like everybody in the room's comfortable, but you're either too hot or too cold,
Yes.
right?
Yes.
Yeah. Have you? Is it too early to tell if you've noticed some improvement in your ability to adapt to room temperature?
Yeah, probably too early. Just because honestly, we were staying in a hotel, and the hotel air wasn't very good.
Yeah.
You know, so that was that was a constant battle before with everyone. So yeah, I would be able to tell more once I get home.
Yeah. Right. Yeah. You need more time to check that
Yeah,
one out.
yeah,
Okay. How about you,
yeah.
Elizabeth? Do you have any questions? Any comments?
No, I don't think I do have any questions.
Okay. We're going to stop for a second here.
Okay.
Okay. Okay, so now we got the kids in the picture here, and is it Sophia? Is that your name?
Yeah, Sophie.
Oh, Sophie. Okay, I got it. And over here we have brother number 2. Now
David.
brother number 2 over here. And what's your name?
David?
David. Okay, nice to meet you, David. And so one of the reasons I wanted to bring the kids into the picture here is because they're an important part of the story, aren't they?
They are.
In 2 ways. Number 1, you went through the ketamine coma and ended up having 2 kids.
Yes.
And I think that's pretty remarkable, don't you?
Yeah. Pretty wonderful. Something I didn't think that I was ever. gonna
Yeah,
do, so,
yeah. I suppose. How old is this one here?
He's 6 months now.
6 months. Okay. Does he know his name yet?
Kieran.
Good job, Karen.
Karen. So how,
Bob Kieran.
yeah, right. And so that's one of the things. And the other thing, reason why I wanted to bring it into the picture, because in terms of your overall rehabilitation, we talked about stress management, didn't we?
Yeah.
We talked about how you need a break every now and then
Yeah,
from
yeah.
this.
Which I'm not good at doing for myself.
I know. So we talked about why that's important to your overall rehabilitation, right? Okay. So so that was one of the things that we wanted to make sure we covered. Okay. Now I want to turn over here and ask Tabby, would you do me a favor?
Sure.
Could you take the little one with you, and because we got some
Sure.
things we want to cover here.
I'll take you
No,
any
not very
day.
good.
Yeah, just in case he comes.
There we go.
Just in case.
He's just on loan.
Just in case he spits up on your clothes.
Yes.
Okay.
We'll give
Okay.
you a binky just in case. Do I leave the room?
Yeah. Okay. Now, Matt, I want to go over one other thing with you here. You remember, creature comforts are very important during the ketamine infusion.
Right.
Because if the patient's not comfortable and they're feeling anxious and fearful, it is you can't get the dose up high. So tell us about some of the things that we did to try to keep Elizabeth comfortable during during infusion.
I guess number one, close the blinds.
Okay.
Didn't have the noise too loud in there.
Right.
As
In
far
other
as
words, keep the room kind of
TV.
dark, and we had some music we could play if she wanted it, and or she didn't want it. Okay.
Yep.
Try to make it more like home than being in a surgery center. Right.
Sure, sure. Yeah, lights were off almost the whole time.
But
Except
what
when
was the
you
most?
come in and do
What would?
something.
Here's your test question. What was the most important thing to keep her comfortable? There's the one. There's a very clear-cut answer to that.
Most important thing?
Yep. It's you.
Okay, yeah. Well, having somebody there. I was
That's
thinking
right.
most important thing I did.
Someone
Well, geez, I don't
she
know.
knows and
It's
she
also very
trusts.
important. Sure.
Because when you're, and I'm going to use the phrase, when you're losing your mind, because this is what ketamine does. It impairs your cognitive function,
Sure.
as demonstrated in the videos, right?
Just disconnected.
She's disconnected. So having that familiarity of somebody by the bedside is huge, and making it so that she's comfortable. And if she did have an adverse hallucination, which you didn't, right?
No,
You
no, I
did
did
not,
no.
which is rare these days because the way we do it, that it would be over the moment she opens her eyes. Okay? All right. So
we had the videos going. The first 2 days of the treatment, we started on the third day, and then you recommended just turning off the TV and listening to music, less visual stimulation.
Yeah, more serene.
right,
That worked.
right.
Throughout, we were using the gauze dipped in water
Right.
to
Keep her
mouth
lips moist because we
moist.
didn't deliberately make her mouth dry, right?
Right. Yeah,
And we
more so
gave
the
her-
first day.
And we gave her what we call the ring sucker, right?
Yep, had a ring pop.
Sometimes that helps to make them feel more comfortable. So,
Sure.
creature comforts. That's the point. Is the creature comforts are extremely important.
Then the blanket on.
Right.
Fan
Cool
going.
washcloth on the
Right.
face.
Yeah, cool washcloth
Right,
on the forehead.
right, right.
Yeah.
Because if we don't deal with that, if we don't get that right, we can't get the dose up high. It just won't happen.
Yeah.
Okay. All right. Very good.